Good morning, everyone. Today's class is on adverse drug reaction and drug interactions. So, I will be talking about what adverse drug reactions are, how do we monitor adverse drug reactions, and what are the different kinds of drug interaction, uh, whether they are synergistic, whether they are antagonistic. So, different types of drug reactions I am going to talk about. So, first, beginning with the adverse drug reactions, what actually adverse drug reaction is. So, at least do no harm to your patient. As per the Hippocratic oaths, also, so it has been said that at least do no harm to your patient. And Hippocrates said that our food should be our medicine and our medicine should be our food. That means the benefit of the medicine should be such that it should be equivalent to our food. That means always it should be benefiting the patient. So coming back into the 1961, you must have heard about the thalidomide disaster. So it occurred because of the use of a drug known as thalidomide in the pregnant females, and the indication for the use of this drug was for vomiting and the morning sickness. So the females who consumed this drug thalidomide, uh, the offspring, the newborns, were uh, having a teratogenicity known as phocomelia, where the limbs were short resembling to that of the seal limbs. There was degeneration of the proximal limbs. And it was Dr. McBride of Australia who reported increased frequency of birth defects, and there were around 10,000 of babies who were disabled for life. Therefore, this disaster resulted into a thought process leading to the development of the monitoring centers which were started worldwide for monitoring of the adverse drug reaction occurring due to the drugs. So adverse effect is any undesirable or unintended consequence of administration of drug. Adverse effect is any undesirable or unintended consequence of drug administration. So there are certain terminologies. Then what is adverse drug reaction? So adverse drug reaction as per the WHO is any response to a drug which is noxious and unintended and which occurs at doses normally used in man for prophylaxis, diagnosis, or therapy of the disease, or for the modification of physiological function. So there are certain terminology that it is noxious or unintended response of a drug, and it occurs at doses which are normally used in man that for diagnosis. That means the therapeutic dose, and the drug is being used for prophylaxis, prevention, or for diagnosis, or for the therapy of disease or for physiological functions. So what are the inclusion factors for a reaction to be called as adverse drug reaction is that it should be a noxious or the harmful response which occurs at a normal dose, and the drug is being used for treatment, prophylaxis, and diagnosis. What are the exclusion factors? What we will not say as adverse drug reaction is poisoning or overdose of a drug when the drug is being taken in larger doses. So there is a difference between adverse drug reaction and the toxicity. That ADR occurs at therapeutic dose, while the toxicity it occurs at a higher dose, such as poisoning. So if you know that metronidazole causes metallic taste. So the normal therapeutic dose of metronidazole is 400 milligram. So if this metallic taste occurs by taking 400 milligram of metronidazole, then it will be called as adverse drug reaction. And if suppose we have consumed 4,000 milligram of metronidazole and we are having this metallic test, then it becomes toxicity. It is no more a adverse drug reaction. So in this log dose response curve also we can see that that the ADR occurs when the drug was being taken in the therapeutic dose range, that is at the lower dose range, and when the dose of the drug becomes very high, then it is known as the toxicity. This part becomes the toxicity. Then there are certain other terminologies also a part of the adverse drug reaction and the toxicity is the adverse event. So adverse event is any noxious reaction which occurs during a therapy. That is, when we take a drug, when we are on certain drugs, these reactions are occurring. But one very important thing is that they do not have any causal relationship, is not mandatory or necessary. That means the occurrence of the event do not necessarily correlates with the intake of the drug. Okay, then another terminology is side effects. Side effects are type of adverse drug reactions in which what happens that uh, that that the reactions are only the extension effect of the drugs. So these are the extension effects of the drug. So I will be telling what. So adverse event, you can see over here that adverse event do not correlate with the dose of the drug. That means the time intake of the drug and the effect which occurs during the therapy do not correlate with the drug. So the adverse event can occur during the when we are on therapy, but it doesn't correlates with the intake of the drugs. While ADR, such as the side effect, they correlate with the therapeutic dose, and toxicity correlates with the very high dose range. So the common ADRs which occurs are the GI symptoms such as nausea, abdominal pain, dyspepsia, diarrhea. Then the respiratory symptoms such as dyspnea, asthma, neurological dizziness, headache, then fatigue, then the cardiovascular areas such as hypertension, pulmonary peripheral edema, then the allergic reactions are very common one such as edema. Then in the blood also there can be thrombocytopenia and purpura, and then in the skin also we can find rashes, pruritus, urticaria, and other. So these are the common type of ADR which occurs by the different drugs, and these are the some of the photographs of the ADR such as bullous eruptions, pemphigoid. This is the photograph. Then this photograph shows the urticaria. These are photographs of allergic reaction, that is urticaria. Then this is a very typical picture of the fixed drug eruptions. So, as per Wills and Brown, we classify ADRs into different types such as type A, which is augmented, type B, bizarre, type C, continuous, type D, delayed, type E, end of therapy, type F, failure, type G, genotoxicity, type H, hypersensitivity, and the unclassified type U. So coming one by one to the type A, which is the augmented, it is the commonest, which accounts for around 70% of the ADRs. It is a dose-dependent ADR, and it can be predicted by the pharmacological mechanism of drug action. Like NSAIDs, they causes prostaglandin synthesis inhibition, and thereby they cause gastric ulcer. Like similarly, like beta blockers, they are antihypertensive drugs, so they can lead to hypotension. And similarly, insulin, we know the insulin causes hypoglycemia. So the hypoglycemia, the ADR of insulin is a type of type A ADR. Type B are those which are bizarre, that means rare, idiosyncratic, or the genetically determined. So these are unpredictable, and the exact mechanism is not known, and they are dose independent, like hepatitis, which is caused by halothane, aplastic anemia by chloramphenicol. So their exact mechanism is not known how these ADRs are occurring. Then the type C ADR occurs with the continuous use of the drug. So these may be irreversible, such as by the constant regular use of the antipsychotic drugs that are dyskinesias occur, or by the use of the anticholinergic medications for a longer duration, dementia can occur. So these type C ADRs are those which occurs due to a long therapy or long duration of use of certain drugs. Then type D is the delayed one, which occurs even after the cessation of the drug. Suppose we have taken a drug for a long duration and then we have stopped, and these ADR occur even some after some certain period of the stoppage of those drugs. Such ADRs are known as type D or the delayed one. For example, is the when we take chloroquine and later on in uh, develop ophthalmopathy or corneal opacities with the use of the antipsychotic thioridazine. So these type of ADR are known as type D ADRs. Then we have the type E ADRs, which occurs with the end of the therapy, or these are the certain withdrawal sort of reactions which occur because of the withdrawal of certain drugs. Like opiate withdrawal leads to hypertension and restlessness, or corticosteroid withdrawal leads to HPA axis suppression, or benzodiazepine withdrawal leads to seizure. So this is the whole summary. The type A is the augmented one, very common one, predictable, low mortality is associated with the type A. So it is like anticholinergic effect of TCAs. Then it can be reduced by reducing the dose or use of certain other medications also. Then type B is the bizarre one, non-dose related, uncommon, but type B is related with high mortality, like penicillin, hypersensitivity, acute porphyria, malignant hypertension, etc. So we have to withhold or avoid the use of these drugs in future. Then type C is the dose related, that is the chronic use, continuous use that I have told you. So for this we can slowly reduce the dose of the drug. Then type D is the delayed one, such as teratogenicity, carcinogenesis. So these are the type D, and type E is the withdrawal one, which occurs with the end of the use of the drug. So here we can reintroduce and withdraw the drug slowly. And type F is unexpected failure of the which occurs due to the failure of the therapy. Inadequate doses of oral contraceptive pills when we are using certain specific enzyme inducers. So this can enzyme inducer can lead to the metabolism of oral contraceptive pills. So these can lead to the failure of the therapy, and this can be overcome by either increasing the dose of the, suppose we increase the dose of the OCPs, or we can consider for certain different drugs also. So the drug teratogenicity, teratogen is an agent that can disturb the development of the normal embryo or the fetus, and it can cause structural or functional deformities in the embryo or the fetus. So the common drug teratogenicity, as I have told, of thalidomide, phocomelia, isotretinoin leads to cleft lip and palate. Then fetal hydantoin syndrome by the use of the drug phenytoin. Then the warfarin syndrome caused by the use of warfarin. So because of all these ADRs or the teratogenicity, the ADR monitoring became important. So as per the Napoleon Bonaparte, he said that I do not want two diseases, one nature made and one is the doctor made. And Paracelsus told that all things are poison and there is nothing that is harmless. It is actually the dose which decide that something is a poison or not. So, what are the different methods of ADR monitoring? In the pre-marketing trials, the the common ADRs are being reported or the data is collected by doing the animal experimentation, then the clinical trials, then the epidemiological studies, which includes the observational studies like case reports, case series. So all these pre-marketing trial data, they compile the adverse reactions which occurs with the use of certain drugs in the population. Then after the pre-marketing trials, we have the post-marketing methods of collecting data on the adverse drug reaction related to the use of the drugs, such as the post-prescription event monitoring. Then we have certain cohort studies where from the hospital-based monitoring of the areas. Then we have the case control studies or the record linkage. Then the meta-analysis of different studies. Then the last is the voluntary reporting of the ADRs by the patient or their attendants to the companies or to the adverse drug monitoring center. And the last is the post marketing surveillance, where what we are doing is that we report all the areas when the drug is in the market, and we are reporting these areas to the adverse drug reaction monitoring center. And for and in our country, India, we have the PVPI, that is the Pharmacovigilance Program of India, which was started in 2010, and the headquarter of this PVPI is situated in Ghaziabad, and there are more than hundreds of, I think it's somewhere around 130, 140 ADR monitoring centers across India, where the different areas are being reported, and these reports are then studied, and then common inferences are drawn, and then it is sent to the CDSCO for further action. And these reports are also being sent to the Upasla Monitoring Center, which is situated in Sweden. It is a WHO ADR monitoring center which is situated over here, and the data from the whole of the world gets collected over here, and the analysis based on these data are being done. So, pharmacovigilance, as per the WHO, is related to the science and the activities which relates to the detection, assessment, understanding, and prevention of the adverse effect or any other drug related problem. So it is not only detecting and assessing, but it is to understand also. And then we have the fourth part, that is the prevention of the adverse effect. So pharmacovigilance, pharmaco means medicine and vigilance means watch. That means we have to be vigilant with the use of the medicine. So what we are going to report to these centers are the serious adverse reactions such as death, life-threatening reactions, hospitalization, disability, or any congenital anomaly. We also report the non-serious, known or the unknown, frequent or rare adverse drug reaction occurring with the use of medicines, vaccines, and the herbal products. Now we have the hemovigilance also, which monitors for the reaction occurring with the blood and the blood products. And there is also there is also monitoring of the medical devices also. So this is the common adverse drug reaction reporting form. Now this is the English form, and we have the form in Hindi also, and there are around 18 or 19 different local languages also. This form has been translated, and the details of the adverse drug reactions are reported on in this form. So where to report? That is, first, this form, duly filled form, has to be of the suspected adverse drug reaction, has to be sent to the nearest ADR monitoring center. And here at JNMC, we are one of the 8 ADR monitoring centers, and the center is situated in the Department of Pharmacology of Jain Medical College. The ADR can be directly sent to the PVPI through these emails, or there is a toll-free number also to report the areas. And these are the certain nationwide websites of ADR monitoring centers. There is an app also through which you can send the ADRs to the ADR monitoring center and PVPI also. So these are the common areas which we these are the common areas which we have reported. We report around more than 30 areas per month and at our center. So what are the benefits of ADR reporting is that these are the certain drugs which have been banned because of the continuous reporting of ADRs related with the use of these drugs. And one more additional benefit of ADR monitoring is that while reporting the different areas, we came to know about certain indications or newer indications of the older drugs, like amantadine, which was originally devised for use in influenza. While reporting, it came to be known that it is beneficial for the Parkinson's disease patients also. Similarly, aspirin, which was actually indicated or which was developed for as an anti-inflammatory drug, because of this, please mute your mic. Mute your mic, please. Daya Lingdo, please mute your mic. Okay, so similarly, n number of drugs which came into existence, like methotrexate, which was actually an anti-cancer drug, which was later okay. Similarly, sildenafil, which was actually indicated for angina, but now it is being used for erectile dysfunction and pulmonary hypertension. So these are the drugs which were originally indicated for certain different indication and now are being used for newer indications. Similarly, bimetocrast, actually, which was indicated for glaucoma, and the common ADR with these prostaglandin analogs was they promoted the uh, growth of the eyelashes. So they are now being used for these indications. So coming to the drug interactions, so the drug interactions can be synergistic, where they can act together when and synergism is when action of one drug is facilitated or increased by the other. They are said to be synergistic, and in the synergistic pair, both the drugs can have action in the same direction, or given alone, one may be inactive but still enhance the action of the other when given together. So the synergism can be additive, where the sum of both the drugs can be equal. That is, effect of drug A plus B is equal to the effect of drug A plus drug B. Example is aspirin plus paracetamol as analgesic, because both the drugs have similar actions, so they will simply add up. But the supra-additive ones are those where there is potentiation. That means the effect of drug A plus B is greater than the effect of the individual drugs when added together. Example is acetylcholine combined with physostigmine. Since physostigmine inhibits the breakdown of acetylcholine, so it will potentiate the effect of the acetylcholine. Similarly, levodopa with the peripheral decarboxylate inhibitors such as carbidopa. So carbidopa will prevent the metabolism of levodopa, peripheral metabolism. So the effect of levodopa will be potentiated. So these are other examples. So this is supraadditive effect. Then there is antagonism when the effect of one drug is decreased or abolished by the action of another. They are said to be antagonists. That means effect of the combination of the drug is less than the effect of the individual drugs. And the antagonism can be of different types, like chemical antagonism, where a drug is like heparin, when it is negatively charged and the antagonist is positively charged, so these forms complexes. So other example is the chelating agent. Then we have the physical antagonism, where due to the physical properties of the drug, they act as antagonists for the other drug. Like activated charcoal, it absorbs alkaloids and can prevent their absorption. So they are used in alkaloid poisoning. Then the third is the physiological or the functional antagonist, where two drugs act on different receptors or by different mechanisms, but have opposite effects on same physiological function. That is, have pharmacological effect in opposite direction. That means both are acting through different mechanisms. Example, like histamine and adrenaline, they are physiological antagonists on bronchial muscles and blood pressures. Like histamine, it causes bronchoconstriction, while the adrenaline, it causes bronchodilation. The effect is opposite on the same system, but histamine acts through the H1 receptors, while adrenaline is going to act through the beta receptors. So the effect is through different routes. Similarly, glucagon and insulin on blood sugar levels. Glucagon, insulin, it decreases blood sugar. Glucagon increases blood sugar, but they are acting on the different cell types of the pancreas. Then there are pharmacokinetic antagonists, where one drug affects the absorption, metabolism, or excretion of the other drug and reduces their effect. Example is warfarin in presence of phenobarbital. Warfarin metabolism is increased since phenobarbital is an enzyme inducer, and it will increase the metabolism of warfarin. So its effect is reduced. So that is a kind of pharmacokinetic antagonism. There are n number of pharmacokinetic antagonists, where the drug are going to act on the absorption, metabolism, or the excretion phase of the drug. Then we have the pharmacological antagonism, where two drugs act at the same receptors. And this type of antagonism can be of two types. One is the reversible or the competitive one, and the other is the non-competitive antagonism. So in the reversible antagonism, what happens? The two drugs are acting on the same side of the receptors and antagonizing the effect of the other. So by increasing the concentration, we can overcome the reverse competitive antagonism. Example is atropine is a competitive antagonist of acetylcholine. The irreversible or non-competitive antagonism where is are those where the antagonism occurs when the antagonist dissociate very slowly or not at all with the receptor, and this results in no change when the agonists are applied or increased in concentration. So the antagonist effect cannot be overcome by increasing the concentration of the agonist. Through this graph, I wanted to show you that uh, if A is the agonist and B is the antagonist over here, so even though we are increasing the dose of the antagonist, what happens by increasing the dose? This side, the dose of the agonist is increasing. So finally, we are going to reach to the maximum effect, okay, by increasing the concentration of the agonist. But in in the non-competitive, this graph B graph shows the non-competitive antagonist, where when we increase the non-competitive antagonist, then we are not going to increase achieve the response even after increasing the dose of the drug. So this is non-competitive antagonist. If you have any question, you can send me mail. Thank you very much.